Hello, this is Dr. Hausinger, and this is the lecture for CDP 401, Treatment of Addiction, Chapter 1 in the Substance Abuse Counseling text by Lewis, Dana, and Blevins. After reading this chapter and listening to the lecture, our objectives are to describe modern approaches to substance abuse counseling and conceptualizations, define substance abuse, characterize evidence-based practices, articulate best approaches to conceptualizing substance abuse counseling approaches, delineate pharmacological approaches to treating substance use disorders, outline multicultural approaches to treating substance use disorders, explain a social justice view of substance abuse counseling, apply ethical concepts to caring for individuals with substance use problems, develop examples of different treatment modalities and their utilization, and paraphrase effective and comprehensive approaches to substance use disorder treatment. Okay. So first off, your text has a very strengths-based perspective, and I want to quote from the book for a second. The myth at the center of past practice involved the notion that clients dealing with substance abuse issues were different from other human beings and could not enter the collaborative relationships that counselors normally like to build with their clients. And this was often under the veil of, oh, you're in denial. Unless you do what I tell you to do or what I think you should be doing, you're in denial. We're moving towards a strengths-based perspective utilizing motivational interviewing, which is the subject of Chapter 3, which frames things differently, that ambivalence or the inability to make change is not necessarily denial or an unwillingness, and unwillingness here is irrelevant. It gives us rich information that we can work on with the person to describe what's going on in the background and to help the person move past the point of ambivalence towards effective change, whatever that might look like. Now, whether or not you decide to go on to be a CD counselor or not, actually, we're not using CD anymore. It's a recent change. We're transitioning to substance use disorder professional instead of chemical dependency professional. Whether or not you choose to be a substance use disorder professional or not specifically, any aspect of human services, social work, psychology is going to be affected by substance use. Okay? And so you're going to see it everywhere. And so we see this in our personal lives, in our professional lives, and then, of course, with our clients. Right. We have national initiatives designed to improve substance abuse treatment, that there should be no wrong door to treatment, which means that if somebody goes to jail and they decide to get treatment, that's okay. If somebody decides on their own, that's okay. If somebody has an intervention, that's okay. So that there's really no wrong way to get to the point of treatment and recovery. Effective systems ensure that an individual needing treatment will be identified and assessed and will receive treatment either directly or through appropriate referral, no matter where they enter into that, whether it's school, whether it's through another type of counseling, etc. Okay. So let's define substance use. And let's define drug. In our working definition, use of a drug that modifies the moods or behaviors of the user is not necessarily considered substance abuse unless the user's functioning is negatively affected. The authors often differentiate between substance abuse and addiction, defining a client's problem as addiction only when physical symptoms of withdrawal or tolerance to the substance are present. The truth of the matter is that the majority of people that use substances are not addicted to them and might not even have problem use with them. About 10% of the population does have a severe problem, and only a very small part of that 10% actually make it to treatment. Okay. So just because there is use there doesn't necessarily mean that it's to the level of addiction, which for the purposes here, when there's physical symptoms of withdrawal or tolerance to the substance. Okay. All right. Okay, so let's look at substance abuse counseling. Substance abuse counseling should be defined as a practice that is evidence-based, respectful, and positive towards clients, complex, collaborative, contextual, multiculturally competent, and oriented towards social justice and built on a strong base of professional ethics. So what are evidence-based practices? In general, evidence-based practices are approaches to prevention or treatment that are validated by some form of documented scientific evidence and stand in contrast to approaches that are based on tradition, convention, belief, or anecdotal evidence. Just a word of caution here. Just because there's evidence does not necessarily mean that it is a best practice. Okay, so we can have evidence saying that something is effective. We could have 10 studies saying that it's effective, and then we can have 100 studies saying that it's not effective. So be careful to really scrutinize this evidence-based practices and do the research on it. The key to success for a substance counselor is simply to be aware of the advances in the field and to integrate these advances into one's practice. Okay. There is a National Registry of Evidence-Based Programs and Practices through SAMHSA, and it's searchable, and you can look at a variety of different programmings for suicide prevention and substance use treatment as well. Okay. And you can look at how they are rated and what the evidence there is to support them. And ones that have the strong ratings are motivational enhancement therapy, motivational interviewing, relapse prevention, 12-step facilitation, behavioral couples therapy, and skills training. Okay. Chapter 3 will outline motivational interviewing. And a key proponent of this is that the motivational interviewer knows that the decision to change comes not from the client's basic traits, but from the counselor-client interaction. The seemingly simple intervention can bring about significant change, and that really comes down to the empathy that the counselor has shown, and we'll cover more of that in Chapter 3. Okay. So if a counselor is showing empathy and shows hope and belief in the client, then the person's self-efficacy can improve. Okay. All right. So one of the main changes in the field came about in 2013 with the latest version of the DSM-5, the APA's diagnostic manual. Went from the 4th version to the 5th version in 2013. One of the biggest changes is how we diagnose people. It's no longer a dichotomy whether you have drug abuse or drug dependence. Now we're looking at it on a scale. Mild use, moderate, and severe use, and we want to look at each substance individually. And so that's in our ASM Dimension 5, where we take a detailed use history. Sometimes the use history is taken in Dimension 1, but most often in Dimension 5. Okay. The use of a dichotomous diagnosis, whether of alcoholism or drug addiction, actually interferes with treatment planning by masking individual differences. People are very complex, and it's not an either-or type thing. Okay. And the insistence on a clear diagnosis of alcoholism, for example, drives away from treatment many people who are not necessarily dependent on alcohol, but who could benefit from assistance in dealing with life problems associated with incipient alcohol use. All right. So what this is saying is that we're potentially, if we use this dichotomous labeling, that we're potentially shoving people away that really could benefit from life skills and different techniques and the beneficial relationship of a therapeutic relationship. Okay. Many treatment providers label a client's hesitancy as denial and wait for the concept of rock bottom to hit. And in reality, that shoves a lot of people away. And again, going back to the no wrong door treatment, we want to encourage anybody. And it's not a competition. So one of the main arguments of some peer support can be it's like a competition. Oh yeah, you think you're an alcoholic? You only crashed 1 car. I crashed 5 cars, and that's not very helpful. Because again, there's no wrong door to treatment. So we want to be able to reach people at all levels of use and encourage them to evaluate their lives and make healthy decisions that are best for them, not waiting until the end. Okay. Great. It's important that we recognize that this is a collaborative relationship and a collaborative partnership. And it's not, I'm not telling you what to do, we're working together to set goals. And the client's substance use has to be considered in the context of other life problems, and not necessarily in terms of causality. And that's very much a family systems perspective, where everything is like a domino and we're interplaying the roles of all of these different things. And it's not necessarily a case of causation, but how things react to each other. Think of physics. Um, it's not really the counselor's business to determine whether problems are caused as or a result of substance abuse, but to look at the whole contextual framework. Okay. On page 9, we have a list of different things that substance abuse counseling can help with. Resolving or avoiding legal problems, attaining financial stability, attaining stability in family relationships, setting and meeting career goals, improving social skills, improving assertion skills, enhancing physical health and fitness, learning more effective methods for coping with stress, developing more effective problem solving and decision making skills, learning relaxation skills, learning to recognize and express feelings, adapting more effectively to work or school, developing social support systems, increasing involvement and reaction in social pursuits, dealing with mental health issues, and increasing self-esteem and self-efficacy. None of that is necessarily substance specific. In fact, pretty much everybody could benefit from some work in those areas. Okay. Right. Now we're going to talk about medication-assisted treatment in a moment and what that looks like. And because of our current opioid problem in the United States, we're seeing more and more treatment centers that were abstinence-based, abstinence-only, looking at medication-assisted therapy. And the controversy there is alcohol. With alcohol, we have antabuse, which would cause a person to become very, very ill. If they had alcohol, they would violently vomit. And then we have things that can curb cravings. However, the idea of controlled drinking or moderated drinking is not something that a lot of treatment centers look at. If a person enters intensive outpatient, or of course inpatient, they're expected to be abstinent from the drug, especially if it's alcohol. But there's this idea of controlled drinking, or for a person that might not want to give up drinking completely. And in many cases, that's considered to be woo, or considered to be counterproductive. In harm reduction, we need to actually look at that. There certainly are individuals for whom controlled drinking is inappropriate, just as there are individuals more likely to relapse when they attempt abstinence. And again, going back to the no wrong door, if a person says, I don't want to give up drinking completely, but I want to cut back, there are things that we can do. There's medications that can be taken, naltrexone, for example, with the Sinclair method, that can help that. And so again, we're looking at, back to that definition, can we get to a point where the person could potentially use without having negative consequences and bring harm to their life? And for some people, that is yes. Clinicians who are frightened by the concept of controlled drinking tend to believe that although many people would be harmed by a goal of moderation, none would be put at a particular risk by striving for abstinence. Interesting. So we want to look at harm reduction. Several researchers point out that requiring abstinence as a precondition for receiving help may place an unnecessary barrier in the way of entry into treatment. Instead, the researchers suggest that we should meet people on their own terms and thereby encourage small steps toward positive change. Okay. So let's look at medication-assisted treatment. A misconception with medication-assisted treatment is that it's a substitution for one drug for another, but it's really a harm reduction method. In contrast, these medications relieve the withdrawal symptoms and psychological cravings that cause chemical imbalances in the body. Okay. We're probably most familiar with opioid dependency medications such as methadone, buprenorphine, and naltrexone, which are used to treat opiate dependence and addiction to short-acting opiates such as heroin, morphine, and codeine, as well as the semi-synthetic opiates like oxycodone and hydrocodone. People can take it for months, years, or forever. Then we have opiate overdose prevention medication, which is naloxone, also known as Narcan. So if a person is nodding out, or they're showing that they are overdosing and perhaps seizing, this can bring them back from the brink of death. And then we have use for alcohol use disorder medications. Disulfiram, ecaprosate, and naltrexone are very common. There is a method called the Sinclair method, which is using naltrexone for pharmacological extinction, which is the process in which the brain is brought back to the pre-addiction stage. Dr. Sinclair is an American physician that's been using this in Finland for about 17 or 18 years now, and it has a 76 to 78% success rate, and about a quarter of the people that try this method do decide to be abstinent, whereas the others continue drinking in a non-problematic manner. If a person wants to continue drinking every day, then they would take the pill every day. Otherwise, a person would take their naltrexone about an hour before they drink. And this involves charting how much they drink and how they feel. And so this is particularly helpful for binge drinkers or for people that cannot stop at one or two and find themselves drinking much more than they'd intended. They find that they don't want to and the cravings are not there, but it allows the person to drink in moderation and or leading to abstinence. Okay. Great. As of right now, they've tried to look at medications for methamphetamine, but nothing has really worked for methamphetamine. So when we look at MATs, we're primarily looking at alcohol and opiates, and also nicotine. I'm sure many of you are familiar with the patch and Nicorette gum or nicotine gum as well. So those are examples. Okay. So one of the things that we need to look at is the social context. A fundamental attribution error is a common error that skews the ways in which people explain human behaviors. Too often, the counseling spotlight stays on the client's diagnosis rather than on their strengths and on their personal vulnerabilities rather than their environments. And what happens is the person feels powerless. There's a nice little thing that you can add to the assessments called a SNAP, which stands for Strengths, Needs, Abilities, and Preferences. This is self-reported by the client. So you ask your client, what are your strengths? What are you good at? And then abilities. What are you maybe naturally inclined to? Strengths, abilities, preferences. What are your preferences? That would be, I prefer to have a counselor of the same gender, or I prefer one-on-ones to group. Needs, of course, would be, what do you need? Do you need housing? Do you need retraining? Do you need to find a job? Do you need to get your GED, etc.? So strengths, needs, abilities, and preferences. And so there are a lot of things that we can do, and our overall counseling orientation should be very strengths-based as well. Okay. There are several different theories of addiction as well, and on page 12, there's just a brief overview of that. However, regardless of how we're choosing to look at addiction, how we choose to counsel is very important with empathy and a strengths-based perspective. We want to empower the client, okay, where we look at the strengths. We look at the intersectionality, the social, political, economic, and cultural factors that affect the clients. We recognize the signs that indicate that an individual's behaviors and concerns reflect responses to systemic or internalized oppression. We help those at an appropriate developmental level identify the external barriers that affect their development, train students and clients in self-advocacy skills, help students and clients create self-advocacy action plans, and assist in carrying out those action plans. So going back to collaboration. Okay. And all of this leads into multidimensional treatment. People are not two-dimensional beings. When we look at the ASAM, we assess on 6 different dimensions. And when we look at those dimensions, we have to look at multiculturalism. So looking at our diverse client populations, the importance of context, looking at fresh perspectives, perhaps engaging in staffing, and showing flexibility. So the multicultural counseling competencies fall into the 3 general areas. the counselor's awareness of his or her own assumptions, values, and biases. So this is the person of the counselor. The counselor's understanding of the worldview of the culturally different client, and the counselor's ability to develop appropriate intervention strategies and techniques. This is where diversity training comes in, and it is mandatory. Most agencies require that every year, but also if you are becoming a substance use disorder professional in Washington and you have your CDP, or now going to be SUDP, every 2 years after you get your full credential, you have to show proof of ethics training and diversity and multicultural training as well. Okay. So we are in a system where our healthcare is becoming integrated more and more, but there are healthcare disparities. The United States is the only superpower that does not offer healthcare to everybody. We have millions of people that do not have healthcare. And so all treatment is not equal, whether you can pay for it or not. However, all insurance companies, whether it's state or low income, Medicare, Medicaid, etc., all insurance companies have to offer some type of mental health and substance abuse counseling services. Previously, they did not, and now they do. So regardless of the type of coverage somebody has, if they have coverage, insurance has to cover some type of treatment. But what that looks like does vary between different insurances. Okay. All right. In addition to this, we do have the truth that we've had mandatory minimum sentencing laws, and that our drug laws are very racist. The majority of people in the United States that use drugs and alcohol are Caucasian. However, the people that get arrested for drugs and alcohol are incredibly disproportionately of Hispanic ethnicity and of different races, specifically Black. Okay, so we need to look at this and look at social justice and advocacy in terms of our roles as counselors. And this is one of the things that's reflected in the DSM-5. So previously in the DSM-4, one of the clinical criteria for diagnosing whether somebody had a chemical dependency problem or not was looking at, have you been arrested? Have you been arrested for drugs or alcohol? And because this is a systemic problem with racism and corruption, really, we can't use this as a true clinical criteria. So that was taken out, right? Okay. So we are moving ahead, slowly but surely. Now, in terms of ethics, we are bound by several different entities. So the NADAC is our governing body, the National Association of Addiction Professionals, and we also have to follow the WACs and the RCWs in our state, and then whatever ethical codes your agency has as well. If you're a social worker, you follow the NASA. If you are MFT, you follow that as well. Okay. So there's several different principles that are the pillars of ethics. So if you took 400 with me, you had this. Client autonomy, non-malfeasance, which is avoiding harm, beneficence, working for the good of clients, justice, treating others fairly and equitably, and fidelity and veracity, being true to promises and trustworthy in relationships. And so these are the pillars of ethics that we uphold, and we have to look at these in terms of making decisions with and for our clients. All right. So for example, if we're looking at client autonomy on page 20, here's an example. When new clients come in, John says that his initial goal is to get them to accept that they are addicts or alcoholics. When clients continue to deny a problem with alcohol and drugs, John confronts their beliefs and values until they accept that they are addicted. John says that clients who never accept that they are addicted usually drop out of treatment. So this could be a violation of autonomy. The fact that client autonomy is clearly included as a requirement, or at least an aspiration. is likely to have a positive impact. So that means we can't tell people things like that or demand that they see things through a certain worldview. Okay. All right. Ethics are not black or white, and what is legal is not always ethical, and what is ethical is not always legal, and it's all gray area, and there are always exceptions and outliers as well. So it's very important for you as a counselor and as a professional to have an ongoing conversation with yourself and with your supervisor as well. And ethical conundrums will come up and they will throw wrenches into things, and we have to work through them. Great. So now we're going to talk a little bit about the different settings that you will find substance counselors in. And what we're going to do is look at these. So general community settings, okay, we are everywhere. So we might be in homeless shelters, we might be on college campuses, we might be in hospitals, but then there are specific places where you will find substance abuse professionals. Detox, which is short-term treatment designed to oversee the client's safe withdrawal from the abused substance, could be in a medical facility. It often is, like an ER or a wing of a hospital. Okay. There's usually 3 choices for detox: doing it at home, a non-medical detox center, or seeking treatment in a medical setting. And depending on some cases, a doctor might give somebody a cocktail of drugs, like a 3 to 5 day cocktail of drugs, to take it home under supervision. We have residential rehabilitation programs. It might be in a hospital or a non-medical setting. Residential meaning that the person stays overnight. And the goals of these programs include providing clients with social learning frame for understanding their addictive behaviors, helping clients assess their problems, teaching them skills for maintaining abstinence, helping them learn to reinforce their abstinence, and teaching them about relapse management. Okay. Right. Unfortunately, sometimes programs are too didactic and don't have the individual level of care needed, and they might substitute education about drugs and alcohol instead of individualized treatment. And we know that teaching people about drugs and alcohol, like lectures and education information, doesn't curb use at all. In fact, it can have the opposite effect. Another venue for substance abuse treatment would be therapeutic communities. And these can often be found in prison. They can be a voluntary program where mutual help remains a very core value. Okay. All right. This would also look like clean and sober housing as well. We spoke a little bit about MATs earlier. You might find drug and alcohol counselors and methadone maintenance programs. Oftentimes these are run by the Department of Health. And then we are often at outpatient counselings where you have different levels of care: intensive outpatient, and the different varieties within outpatient. Okay. Outpatient counseling allows for a high degree of individualization. It encourages clients the development of treatment plans based on long-term and short-term goals, and it gives the client an opportunity to try out new behaviors in ordinary environments. So in outpatient, a person's living at their residence or wherever they live, and they're coming to classes. And it's usually a graduated process. And in Washington, we have WACs and RCWs that tell us exactly what that has to look like, how many hours a week a person has to go to in order for it to qualify as inpatient or IOP or outpatient. And then another place that you'll find drug and alcohol counselors are employee assistant programs, which are through the person's place of employment. If a person is getting written up at work for being late and it's determined that it's because of drug or alcohol use, they might be required to go through a program in order to keep their job. And addiction is covered under the ADA. So this is a very positive thing, and oftentimes we can get around insurance companies by the EAP and saying, look, the person has to go to treatment in order to keep their job, which is protected class, so you must pay for it. You must pay for it. Okay. All right. Okay. So As a review, we need to have these different qualities here in order to have competent practice. MATs, we'll talk a little bit more about this later on and go over what they do and why they do that. It is important to know that a form of treatment could be very effective on its own, but if we couple it with other treatments, it could be even more effective. And the analogy is this. If you want to exercise and get fit, you can exercise, but if that's all you're doing, you're probably going to have some results, but you'll have even more results if you pair that with a healthy diet, and maybe even more results if you pair that with some type of social support or health and wellness coach. And it's the same thing with addiction treatment. We can give somebody a pill and curb their cravings, but we're going to have much greater results and potentially long-lasting results if we pair that with some type of counseling and social support. Okay. Right, so we will be continuing to have the ethical discussion throughout the semester. If you have any questions, please relate it to the Voxer discussion for this week, and I look forward to seeing you online.